Good morning. Today we will have operative surgery discussion. The presenter will be Dr. Indrani Devnath, who is a second year junior resident at Calcutta National Medical College and now at MR Bangalore Hospital on district residency program. So we'll have two topics for discussion. Today is a herniotomy for congenital hernia and eversion of sac for hydrocele. So Professor Shubhar Maiti, Professor and Head of Surgery at Eye Care Institute of Medical Sciences at Haldia. Dr. Maiti will take us through this operative discussion. So Dr. Indrani Devnath is here. Dr. Maiti, you can start. We start with herniotomy for congenital hernia.
Okay, welcome all of you. Thank you, Professor Saha, organizing this type of classes. And I welcome Dr. Indrani, and I hope we will now go through the discussion on herniotomy and eversion of the sac. So our discussion on herniotomy will be in the children, and the discussion on eversion of the sac hopefully will be in the adult, because eversion of the sac is rarely performed in the children. Okay.
Yes.
So Indrani, have you seen any case of herniotomy in the OT, in the pediatric surgery or general surgery OT?
Yes, sir. I've seen.
You have seen. And what is the indication of herniotomy?
So in case of congenital inguinal hernia, we're usually doing herniotomy.
Okay. So what do you mean by herniotomy?
So herniotomy is basically a dissection of the sac, and dissection of the hernial sac, and then the contents is reduced, and the neck and the transfixation is done with the neck. And it is
and division.
And division is done.
Distal part remain open.
Distal part remain open. It's remain cut and open.
Okay, fine. So that is herniotomy. So other two terms we should know, what is herniorrhaphy and what is hernioplasty.
So hernioplasty is basically when after herniotomy we are putting a mesh, and in herniorrhaphy is we are just doing the posterior strengthening, like without putting the mesh. Okay. Like here we are just.
Can you mention a pioneer surgeon who popularized and just made the herniorrhaphy very simple, and that was followed throughout decades, years? Herniorrhapy is basically named. There are different types of herniorrhaphy.
Yes.
One popular is a particular name. His name is that we know. We want to know the name because he revolutionized the repair of hernia. Bessini. Remember the name of Bessini. Bessini. Though it is not popular now, but yet in some cases it is still performed instead of hernioplasty. Okay. Now coming to herniotomy, you have to operate in herniotomy under what anesthesia?
So usually we're doing under general anesthesia.
General anesthesia. And you see that sometimes in older children, the expert anesthetist sometimes prefer spinal. But your answer will be always in exam as the general anesthesia.
Yes.
Okay. Herniotomy, what are the different types of hernia in children? How will you classify the hernia in children?
Inguinal hernia.
Okay.
What is the usual type? What happens in
adult? In adult, you know, there are different types of hernia. In children, it is also same. So that's enumerate what are the different types of hernia you can encounter.
Children, so we usually have.
First, think of a complete procedure. It is from the deep ring up to the bottom of the scrotum. So that is what.
So you know it, but you just answer systematically. Okay. So a hernia may be complete.
Complete
And
sac.
also it can be
Complete sac from groin to the bottom of the scrotum. It's a complete inguinal hernia. Complete congenital inguinal hernia. So most of the congenital hernia are like that only. The whole procedure is a patent. Then
there may be the sac is obliterated at the distal end.
yes.
It,
Where? At the upper pole
at
of
the upper
testis.
pole of the testis.
Yes.
That is one type. Another is the sac is obliterated both at the upper pole and the lower pole, and there is some encysted part in between.
Then it will not be hernia.
It will be an encysted cyst.
Is the encysted hydrocele of the spermatic cord.
Encysted hydrocele.
And what is the funicular type of hernia? Funicular.
So funicular type is where the proximal end is obliterated. Yes.
So in that case, what it will be? It will be fluid or it will be gut content?
It will be freed.
Yes.
Okay. So how common is hernia, inguinal hernia in children? How frequent do we get?
If we go to pediatric surgery OT, you will find at least there are 2-3 herniotomy cases being kept. So it's not very uncommon.
It is not so uncommon. Huh? So it is very common, particularly in children, when the child or newborn is a preterm baby. Okay. So in preterm baby, the incidence may be as high as 10%. Remember, and particularly if the child is if the newborn is a low birth weight, how much it will become the incidence? If it is a low birth baby, preterm child, preterm newborn, what can be the incidence? What is your imagination? It may be very high. It may be as high as 30 to 50% if it is a preterm low birth weight baby. Okay. So when we are getting a case of inguinal hernia in a child, also you take always the history, family history. It is about 12%. Family history may be present in 12%. Whatever may be, what is the incision you will prefer for herniotomy?
But just describe the step.
We will discuss the steps. We take the steps one after another, then we will take each
Inguinal canal in
discuss. Indrani,
inguinal canal in Chindel? No. The answer is no. Yeah. The deep ring and social ring is almost
together.
superimposed.
So we give
Okay,
a
so how to make
transverse
the
incision over the
incision?
groin parallel to the incision. So we give a transverse incision in the groin parallel to the inguinal canal. Like and we
How do you mark? You mark the pubic tubercle. You mark the
inguinal canal is not well developed here. Okay, so it may superimpose. So you cannot say parallel to the inguinal canal. Okay, so rather here in case of a newborn or the infant, the incision should be parallel to the groin crease. Okay, instead of the inguinal ligament, mentioning inguinal ligament or inguinal canal, you mention it will be on or parallel to the below and parallel to the groin crease. Okay. Okay, so you made a transverse incision then.
Then we deepen the incision up to skin and superficial fascia. And the superficial bleeders, we just hemostasis of the superficial
which
bleeders.
bleeder can come here as it incides. So yes, because Soviet circumference iliac will not come because you don't give such a large incision. Superficial epigastric vessel may come, that needs to be coagulated and divided.
So after that, we reach up to external oblique, and we give a incision over there.
Okay,
and
stop.
then the external oblique.
Stop. So when you are making incision on the superficial fascia, how many layers you will get? How many layers are in the superficial fascia?
Sir, there will be 2 layers, fascia of Scarpa and fascia of Camper.
Yes.
Which one is superficial?
Scarpa.
No.
Camper is superficial.
Camper is the fatty layer and Scarpa is the fibrous layer. Remember.
Yes.
Remember.
Yes, Dr. Mahit. Yes.
Remember, in infant and children, the fascia Scarpa is so prominent. Sometimes it may simulate like that of the external oblique. So that mistake may happen in children. So in adult, it is not the problem, but in children, fascia Scarpa is very prominent. So take care that never make a mistake that it is external oblique aponeurosis. So after making incision on the fascia Camper and the superficial, that is the layers of Camper and Scarpa, you will get the external oblique. Then approach, then proceed. you will get the external oblique.
So we then make a incision over the external oblique and along the fibers, and then we dissect that. And after that, we after deepening the external oblique, we get the cord with the sac. I mean cord structure with the sac, and we dissect the cord. We dissect the sac from the other cord structure, and after dissecting the
You describe properly. You expose the region of inguinal canal, which may be superimposed deep and superficial ring. Now we have the cord structure in the sac.
yes, sir.
So to reach the sac, what you need to do? What is the step?
We just have to make a parallel. A longitudinal incision over the cord
Structure?
And on the
I'm
longitudinal
looking at you to expose.
longitudinal
So
incision
there
on
will be the external
External formative fascia come in inguinal canal. Try to understand. External formative fascia is a prolongation of external appendage which come beyond the superficial ring.
yes.
You are deep to the superficial ring, so the fascia that will come now will be cremasteric muscle and fascia.
Okay. Yes.
So once a pediatric patient back with the construct, it can be in file and you just incise a cremasteric muscle and fascia, and then is a very fine layer of internal spondylic fascia. Then
Then, sir, after that, we dissect the sac from the rest of the structure, and we
in pediatric patient, if you have sac, if you compare the adult person, adults you can nicely see the white shiny margins.
it's
What
very
in children?
thin, it's a very thin level, pearly white structure. And the vast difference here, what we find is only delicate small structure compared to in adults. So after we get the sac, we delineate the margin of the sac properly, and we hold the margin with some artery forceps. And after
Mosquito, not artery.
with mosquito forceps. And after that, we cut open the sac over the at the fundus. And after that,
Fundus is where? Fundus is the bottom of the scrotum.
yes, not at the fundus.
Okay, so you dissect the body of the hernia sac in the region of inguinal canal. But here you have already decided that you will not try to find the fundus of the sac because fundus sac in the bottom of the scrotum. So you dissect the sac and go up to the region of deep vein, which we identified by what structure? What structure identify that you have reached the neck of the hernial sac? Yes, inferior vesical cross, and there may be a collar of fat pad around the neck. So dissect that area.
Yes, sir.
And in most of the corneal hernias, you can easily reduce the content.
So the content will be
Okay.
reduced inside. Yes.
Yes. Then what?
After that, we will do a transfixation of the sac, and the excess portion will be cut off. And so, if the transfixation is done properly, then
What suture you use for transfixation? What suture you use for transfixing the neck of the hernial sac?
I'm sorry, 30 by
30 polypectin is good enough for transfixing the neck. And then transect the sac, keeping the distal end open. Instead of a round opening, you can make a cut on either side so that the mouth of the sac remain splayed open. Dr. Maiti, is it right? You should cut the.
Yes, right. Okay, Indrani. So you will identify the neck of the sac by the pad of fat outside the neck of the sac. If you look at the inside of the sac, how will you identify that you have reached the neck? If you look at the inside,
constricted part of the sac, sir.
not only the constricted part, but also
Crossed by
a white ring. You may very often find a white ring at the side of the internal opening inside the sac, because there is a thickening of the sac maximum at the side of the internal neck. So how many ligature will apply at the neck? How many ligature? Professor Saha has mentioned 30 vicryl. Then how many ligature? One ligature is sufficient if it is properly made. But usual practice.
some people in the habit of applying two, but one will be good enough.
Okay.
But it should be a transfixation so that it does not slip.
And remember, when you are applying, the technique is when you are applying the second ligature, you apply it after making a twist on the
Yes, sir.
sac. So if you make a twist and that ligate a second ligature on the twisted part, that ensures that you have properly make the content to reduce go back and the fixation will be better. Okay, so if it is a hernia, then if it extend up to the scrotum, you may leave behind the rest of the sac, that is the distal part of the sac intact, making or splaying open the upper end of the remaining sac. But if it is a incomplete sac, which is not extending up to the scrotum, what will you do? Will you leave the distal part of the sac, or you will try to remove it?
It's incomplete.
Incomplete sac. When the fundus is visible, when the fundus of the sac is not visible, if it is a congenital or complete inguinal hernia, then the fundus will extend up to the bottom of the scrotum. But if it is an incomplete hernia, then the fundus will remain within the inguinal canal. So the fundus will end proximal to the superficial inguinal ring. In that case, you may have a complete dissection and excision of the sac. Okay. Okay. And sometimes it happens the inguinal hernia in a child is having or associated with a hydrocele of the distal part. Then what will you do? There is a hernia and a hydrocele at the distal end. We often call it hydrocele of the hernial sac. What will you do with that portion of the hydrocele sac?
For congenital hydrocele, the treatment is same, sir. Like we
No,
do herniotomy itself.
No, herniotomy itself. But what will you do about the sac, hydrocele sac, which is a full sac? Suppose it is the size of 6.
We will say cut open the excess portion of that sac. I mean, we will excise that part of the sac.
That is within the scrotum, around the testis. Will you go to the scrotum?
No, sir. We will take it out from the same incision.
Okay, then will you just mobilize the full length of the hydrocele sac? No. What you will do, you will just open the, you just push the testis and the hydrocele sac upwards towards the inguinal canal by a pressure on the scrotum inferiorly, and when the upper end of the hydrocele sac will come or bulge into the inguinal canal, you dissect the hydrocele sac at the upper end and make a deroofing. Make a deroofing of the sac and just drain out the content of the hydrocele sac. Once you deroof it, then and once you make a discontinuity of the processus vulneraris by your herniotomy, there will be no recurrence of the hydrocele. That is unique thing in the pediatric patient. As you do the eversion of sac for hydrocele, but here you can do only the deroofing at the upper end of the sac. Okay. So now after doing the hernia operation, or when you are doing herniotomy, if it is a very big hernia, suppose there is a wide hernial sac neck, will you do something extra? And you know, always
Deep ring is wide, patulous.
very wide. Suppose in adult, if it is a Gilbert 4 type or Gilbert 3 type, or a very big hernia, making the internal orifice very wide and very weak.
Simple.
Sir,
You can
we can
you can narrow the deep ring.
yes,
How you narrow the deep ring? Not bursting. This
Audio
so
is
you just apply few
audio
between the inguinal ligament.
audio is not working. It is very echoing is too much today.
No, your audio is clear.
No, there is a question in the chat box.
Yes,
So
yes, yes.
before twist, shall we take the bite, or after twist we will take the bite? The first bite should be always by inspection. So when you are passing the needle through the sac, you inspect through which the needle is passing. And the second bite can be made with twist, and there is no need of, and that the second bite should be always distal to the first bite, never
Yeah.
proximal to the first bite. So that
Twisting is not mandatory. Twisting is not mandatory. It was earlier described, but twisting is not mandatory,
Not
even for adult. Even for adult.
not mandatory. Okay, but that is a practice that is usually done, and you should remember also that. So you can make the deep ring or internal ring narrow by plication of the fossa transversalis, or by making a suture of the cremaster muscle, what we have splitted, suture it behind the pod, and that will strengthen the cremasteric fossa, may strengthen the fossa transversalis, and to make the deep ring narrow. Okay. In which situation the posterior wall of the inguinal canal is very, very weak, and the adjacent inguinal muscles are also very weak. In that case, the recurrence is too high. In spite of your good herniotomy, the recurrence may be very high. If there is a defect in the muscles, congenital defect in the muscles. Yes, Dr. Professor.
As such, in pediatric patient, one should not say that I will do a repair of deep ring. For usual case, unless examiner asks specifically.
Herniotomy, you go up to herniotomy, but in case of a very wide ring, you can mention also the narrowing of the deep ring. Only that.
What I'm saying is they should not volunteer. If the examiner want to know that if there is a deep ring being wide, what will you do? Otherwise, they should not spontaneously say that I will narrow the deep ring. Because in a usual pediatric hernia, we don't give this plicating suture. What I'm trying to say, would the candidate volunteer and say that I will narrow the deep ring if it is wide, or let the examiner ask?
Okay. In which situation the recurrence is high? In spite of a good repair, there may be recurrence.
What are the causes of recurrence? One is technical. You have failed to identify the neck of the sac. So you have tied the sac little beyond the deep ring. So that is one important cause of recurrence. And second, Dr. Maiti already answered.
Big deep ring.
Yes.
You know what? Second is what you have mentioned, Indrani. Second is
patulous. Sir, patulous and bigger deep ring.
Yeah, and another thing you should remember, the connective tissue disorder. Ehlers-Danlos syndrome. And there are a few other connective disorder where the muscle is very weak and the recurrence is very high in those cases. Okay. So in herniotomy, sometimes you have to add something. Some associated defect may be present in the child. What are those? Phimosis. You always exclude the presence of phimosis. If you do not correct the phimosis at the same time, the chance of recurrence will also be high, because of the pressure, increased intra-abdominal pressure, because of the presence of phimosis. So there may be more chance of recurrence. So if there is a phimosis, you must correct the phimosis along with your herniotomy. Okay. But other thing may be associated with hernia. At the same time, you have to correct that defect. That is not so uncommon. Before operation, you should
mention hydrocele.
Hydrocele we have discussed. Another thing you must search for before your operation.
So this is we have to explore the contralateral side also.
No, undescended. There may be associated
undescended testis.
Undescended testis.
Undescended testis. So if you do not correct the undescended testis by orchiopexy at the same time, it will be very difficult to correct as a second operation, or it is not good. Okay, so undescended you must examine the scrotum properly, whether testis has descended or not. And if it is a undescended testis along with hernia, you must do the orthopexy along with herniotomy. Okay. Okay. If you find a content as a gonad, then what suspicion you may make? On the other side, suppose in a female, there may be a hernia. In a female child, if you find a gonad in the inguinal canal or in the hernial sac, what thing you must keep in your mind and investigate the patient?
This is another important condition, that gonads are found in female patient in the inguinal canal. So the other patient who may have.
In female patient, if you find a gonad, any student who are participating, any participant, they can answer. Other than Indrani, anyone can answer.
Nitesh. Yes, the Nitesh is answering is the AIS, androgen incident syndrome.
Okay. And also the testicular feminization syndrome.
Yes.
Remember, in testicular feminization syndrome, you may get also this. It may not be a ovary, it may be a testis. So you should look for, by the side of that gonad, what you are finding in the canal, you should look properly whether there is associated uterine tube present or not. Okay, or it is looking like a gonad with vas deferens. So by your inspection, you may guess whether it is testis or not. And further, after the operation, you should the chromosomal study and you should do the ultrasonography of the abdomen, or you may do the endoscopy, the genitoscopy, to confirm whether it is a female sex or a male sex genotype. Okay.
Or these are mostly hermaphrodite.
So in a case of hernia operation, before operation, you should also examine properly the child to prevent the chance of recurrence. Other than this phimosis, what you should, and other than the connective tissue disorders, what other things you must look for?
Some form of urethral obstruction.
You look for spine. You look for spine. If there is a spina bifida or meningocele, there may be also the associated hernia, and you should exclude and you should remember that this patient may have also recurrence. The chance of recurrence is high in the presence of meningocele or meningomyelin or spina bifida, because there is also the nerve defect. Okay. The nerve supply of that particular region may be disturbed. Okay. Professor Saha, ask question.
Yes, yes. And also one should exclude if the patient child has staining during micturition, one should suspect posterior urethral valve also. To exclude a posterior valve, you should do ultrasonography and see whether there is bladder distension or there is any hydrophobic change. So you should exclude some staining factors so that can prevent the herniation in the post-op. And any post-op complications following herniotomy? Post-op, when do you discharge this patient? After surgery, when you discharge this patient?
So after 1 or 2 days.
2 days is too much. Now most of them are doing daycare surgery.
Daycare surgery.
Most of the herniotomy are done as daycare. That means you give anesthesia in the morning, by evening you can discharge the patient. Or at best you discharge next morning. 2 days stay is not required for just a simple herniotomy. What will be the post-op complications?
Indrani,
herniotomy.
Indrani, suppose you have detected the hernia in a child of your 3 months. When you take the decision to operate? Suppose you have seen a child at 3 months, in a male child of 3 months, you have found inguinal hernia. What is the timing of your operation?
As early as possible, because otherwise there might be a risk of strangulation or incarceration. So we do not do it.
Yes. So if younger is the child, more is the chance of incarceration or obstruction. So below 3 months, the incidence of irreducibility or the obstruction is too high. So younger the child, earlier will be the age of operation. And if you find there is a associated undescended testis, you operate as early as possible. Once a patient with undescended testis having a obstructed hernia, it becomes very difficult to save the testis when you are operating a operation of obstructed or strangulated inguinal hernia in a child. So whenever you detect a undescended testis along with hernia, you take the decision to have the operation at the earliest possible time. Okay.
So complications, post-op complications. Chalo?
So post-operatively, sir, there maybe initially there may be pain and swelling.
Pain is not a complication.
And
Swelling is because of what?
So because of the dissection.
Professor Saha, there is a question in the chat
Yes.
by Professor Banerjee. So
Yes, antibiotic. I understand, but then later answer this.
will you
Yes.
use antibiotic or no
Antibiotic.
antibiotic?
Sir, usually, sir, inguinal herniatomy, herniatomy is a sir open, clean procedure. So usually, sir, antibiotic.
So standard recommendation is no antibiotic. But most of the time people give 2 or 3 doses of antibiotic as prophylactic. But standard, if you are asking me, standard question answer would be antibiotic is not indicated in patient who has got a herniotomy being done.
Any of the cephalosporin group or amoxiclav.
Yes.
That is the preferable antibiotics.
2 or 3 doses. Okay, then one is swelling it because of bleeding. Try to understand. In a post-op hernia, you may have bleeding. Then while operating, you may have some other complication. Injure the vas. You can injure the spermatic cord vessels, leading to delayed testicular atrophy. Okay.
And if you when you are dissecting the sac, take care that you will never touch the vas. Never touch the vas. Always dissect the sac, hugging the wall of the sac. Remove all the fibrous tissue from the surface of the hernial sac, and then if you push the fibrous tissue from the surface of the sac, that will push the cord structure, that is the vas and the testicular vessels. So never touch, try to never touch the vas deferens and the testicular vessels. Okay, then it will protect. So avoid injury. It is very vulnerable. Very vulnerable to have the injury. Okay.
Okay. We can pass on to hydrocele.
Okay. And another thing, before going to hydrocele, we should discuss something on the repair, type of repair. Will you always go for open surgery, or you will also opt for laparoscopic? It is the possibility of laparoscopic surgery in children. Yes, you can also go for laparoscopic repair. What is the advantage of doing laparoscopic surgery?
We can look for the contralateral side also. Like if there is any contralateral inguinal hernia present,
fine.
Then we can detect it.
Yes, I understand your point. So other than the laparoscopic technique, what is the other way of getting an idea about the opposite side?
So we can do imaging, like ESG we can do.
Okay.
Ultrasonography.
So it is now become a standard practice to do ultrasonography in each and every case, because if you get a processus vaginalis on the opposite side, patent processus vaginalis on the opposite side, without any clinical hernia, that should be recorded. Because if you operate suppose on the left side, and after 2 months, there is a hernia on the right side, then the parents, innocent, maybe they may think that because of the operation on the right side, the hernia on the left side, the hernia on the other side has occurred. So you should keep in record that on the other side there is a patent processus vaginalis. Patent processus vaginalis may not be the cause for the subsequent, or may not cause the hernia subsequent. It may disappear. Initially, the standard practice was to do repair on the other side if there is patent processus vaginalis, but now it is avoided. Until and unless there is a clinical hernia, you may not touch the other side. But when you are going a laparoscopic repair, then you can put a bite to close the internal ring if you find a patent processus vaginalis on the opposite side during laparoscopic surgery. But in open surgery, if in spite of presence of a patent processus vaginalis, never try to explore the other side without if there is no clinical hernia. Okay, now we pass to
and keep in mind. And keep in mind, during laparoscopic repair, the hernia and the laparoscopy started just putting at the deep ring. That resulted in hydrocele of the distal part of the sac. So now the technique is you incise near the deep ring so that the distal part remains open. And in the proximal cut margin of the sac, you apply the pursing. So that you don't just apply a pursing so that the distal end remain blind. So the technique in laparoscopy will be you find the deep ring area, hold the sac, and then make a circumferential incision so that the distal part remains open, and the proximal cut margin you just apply a pursing suture. So that is a laparoscopic herniotomy. I think we can go to the hydrocele.
Skin, how to close the skin in pediatric patient?
Yes.
Skin closure. Skin closure.
Skin
How do-
closure we give subcuticular suture.
Yeah.
Yes.
So that there is no hassle in removing the suture.
Almost always it is done. And another thing you must remember, in very small child, infant, rather 1 month, 2 months, if you are going to, if you are operating, then the incision is almost over the superficial inguinal ring. Okay, in that case, you may not incise the external oblique. But in an older child, you better to enter into the inguinal canal by making incision through the external oblique aponeurosis. Okay, next we pass.
So you can pass on the hydrocele, yes. And before you start hydrocele, I know an examiner who is objecting to the term saying vaginal hydrocele. Dr. Srivastava used to say that there is no vagina in male. So the correct terminology will be hydrocele of the tunica vaginalis sac. It's not vaginal hydrocele. It's a hydrocele of tunica vaginalis sac.
Very good. Just like the term toilet mastectomy.
Yes.
The term toilet mastectomy, always say palliative mastectomy.
Yeah.
Okay,
Okay.
proceed. So proceed with a eversion of sac in a person, in a male that is 40 years aged, unilateral eversion of the sac.
Yes. Steps.
Steps.
Sir, we can do it either on spinal anesthesia or we can,
In exam, practical exam, you answer what you do. It's not the options of 2, 3, 4. You are offered a patient of unilateral vaginal tunica vaginalis sac, you are operating. You just say patient in supine position, antiseptic cleaning, and then I will apply local anesthesia. That's it, straight answer. Most of the hydrocele is done under local anesthesia. Tell us, how do you block? How will you block while you are doing a hydrocele operation?
so we give a penile block.
Penile?
I mean, sorry, cord block.
Yes, you need to block the cord first because you'll be holding the manipulating the testis. So you need to block the cord, and then
How do you block and
only cord is blocked.
what
Or
amount of what amount of maximum amount of local anesthesia you can take? And approximate amount, total amount of fluid.
that many people does not know. If you are very clear about the toxic dose, you'll be. I can give you a clear idea. If you are using a plain xylocaine, 2% xylocaine, the limit of dose will be 10 ml for a 60 kg male. If you are using xylocaine with adrenaline, it will be 20 ml. If you go by milligram, you will calculate this amount only. But the better way, if you need a larger volume, you can always dilute this 2%. You can dilute to 1%. Even a 0.5% xylo can provide equal analgesia. So maybe only 10 ml will not be enough for a hydrocele operation. In that case, you should not inject 2%. You should not reach the toxic dose. You need to dilute to 1% or even 0.5%. So you say
until unless you dilute with the normal saline or distilled water, you cannot spread the or place the anesthetic in proper amount in the places where you like to infiltrate. Okay, there are certain places you have to infiltrate the anesthesia. 3 important places. Tell. First, you are going to block the cord. Then
you have blocked the cord, and then you have a median raphe in the scrotum. Where do you inject? Subcutaneously, parallel to median raphe in the line of skin incision. And when you operate in the hydrocele, some posterior scrotal nerves come recurrently from below. So it is wise to place, inject a little amount in the posterior part of the scrotum, so that we block the recurrent nerves coming from the posterior to the scrotum.
So 3 places you remember, one is the cord, another is the line of incision, third is the horizontally, posteriorly to block the posterior scrotal nerves. Okay, so after making infiltration of the anesthesia, proceed.
So then we make.
Will you start operating immediately after injection?
We will wait for.
Wait for at least 10 to 15 minutes. That is the time. You should not start operating because this conduction block takes time to effect. So in most of the time, I do the local block before I scrub.
Yes, exactly.
And then you scrub and wait. Because if you just start operating immediately after injection, patient will cry out of pain. It takes time for the local anesthesia to act. Okay, then.
Proceed. Indrani, we have 15 minutes only.
We make a longitudinal incision, sir, parallel to the median raphe, and we deepen the incision, and all the scrotal layers are dissected.
Layers. You keep on naming. As you come from the skin down, you describe the layers you are cutting through. Skin.
Skin, then sir, superficial layer.
What layer? Do you find fat in the scrotum? There is no fat in the scrotum. So what is that layer after skin?
Superficial spermatic fascia.
Superficial. What muscle? These spermatic fascias are deeper. Once you cut the skin, the first tissue in the subcutaneous tissue is dartos. Skin dartos. Deep to the dartos, 3 cremasteric fascia comes. Tell us.
Sorry, external cremasteric layer.
Not cremasteric. External spermatic fascia, continuation of.
Okay, external oblique.
Aponeurosis. Next layer is. Next layer is cremasteric fascia, continuation of. Internal oblique. Third layer is.
And internal spermatic
continuation of
fascia transversus.
Yes. So as you go layer by layer in the scrotum, skin, dartos, 3 spermatic fascia, external, cremasteric, and intraspermatic fascia. Once you incise this, now what you do? Now you have reached what? What layer is shining layer is seen?
So we'll reach the sac of,
No, what is that layer?
tunica vaginalis.
Which layer?
Visceral layer.
No.
Parietal layer.
Parietal layer. So once you incise it, find the parietal layer. Now what you have to do? Before you incise the tunica vaginalis.
So we have to dissect it from the rest of the dartos muscle and from the
Not dartos.
other structures.
Not dartos. You have incised the dartos and 3 layers.
Surrounding fascia present over there. You have to dissect it.
So the step is, once you incise all the layers, you create a space between the parietal tunica vaginalis and the internal spermatic fascia. So this space is required. After eversion, you have to place the testis back into this sac. Okay. So you have to create a space between the internal spermatic fascia last layer and the parietal tunica vaginalis all around. Now, the assistant is holding from below.
Take the whole sac out. And
okay, that is in one step, but sometimes all people will not take the whole sac out. You can operate keeping that, because you see, if there is a large hydrocele sac, taking the whole sac out requires a very large incision. That is not required. Next is what?
Put an incision over there.
Yes.
And then we just put a suction tube to drain all the content from there. And then we just lengthen the incision.
Extend the incision.
Yes, extend
above
the incision,
and below.
Above and below. And after that, we just take the testis out of it, and then we just divert the
routine version, don't say excise the sac. In a routine version of sac, excision of the sac is not a step. For routine eversion, you just say eversion. You evert the sac and the cut margin is.
And the cut margin is
sutured behind the testis.
Yes.
And as you go up, what is the guide? Where do you stop? Once you start suturing, you are going towards the cords. Somatic cord. Up to which step will continue. There is a guide.
Indrani, when you are just suturing it, there is chance of tightening of the spermatic cord that may cause even necrosis of the testis.
Yes.
So to prevent the necrosis
Yes, sir.
or impairment of circulation to the testis, what preventive measure you will take?
So we take just one finger, sir, so that it doesn't get that much tight when we are closing it.
At least you should keep your little finger by the side of the spermatic cord,
Yes.
and then you assess,
Yes.
then you continue suturing.
Yes, sir.
Proceed then, Professor Saha.
Yes. Then
Sir, after
the eversion is done. Then what do you do?
Sir, the hemostasis is done properly, and then sir, the dartos muscle is.
You have to press it back.
Oh, sorry. Yes, we have to.
Once you have done the eversion, the testis and the
Testis.
sac is out. So you have already created a space between the inner spondylic fascia and the parietal vaginis. To reposition the
Repositioning of the
testis, what precaution you should take while you reposition?
should not get twisted.
Twisted. How do you know you are not twisting?
So represent laterally.
Yes. So you see the sinus of the epididymis. The sinus of the epididymis. There is a cleavage between the epididymis and the testis. So this sinus should look laterally. So while repositioning the testis back to the scrotum, you should ensure that you are not twisting the pelvis. So place it back. Now you have the
And dartos over there.
not dartos, all the layers.
The layers along with the dartos, then we will close with a continuous interlocking suture, and after that we will put a drain and we will close the skin in layers.
Drain is not mandatory. Keep in mind, if you have done a good hemostasis, there is no bleeding. Putting a drain is not mandatory, and most of the people will not allow that I put a drain. So it's not necessary. Drain should not be a routine answer unless you have a very large hernial sac, hydrocele sac which is bleeding, very vascular. Otherwise, a drain is not required. So closer and then close the skin.
Close the skin. Yes.
What is Lord's operation for hydrocele? This is just simple eversion of sac,
Yes.
because I prevent you to not to say the excision of the sac. What is Lord's procedure?
So we just suture the portion of the sac with the testis itself.
With the testis. You don't take the bite from the testis.
Yeah.
Lord's procedure is done in when? You see, in this version, we have not excised the sac. If the sac is large, in some patients you find very large hydrocele, the sac is very redundant. The Lord's procedure is, instead of eversion, you start from the cut margin of the sac and keep on plicating. First plication. Once you tie, the sac curls up and the procedure of the testis. This is usually done for large hydrocele. This is Lord's procedure. Plication of the hydrocele sac. Some people in the practice of doing excision whole sac. What is that operation called as? What is that operation called as?
Hydrocelectomy.
Hydrocelectomy. So that is also not a very common procedure, because hydrocelectomy may cause a lot of bleeding and patient may have costohematoma. But most of the time, if patient is very large, thick sac, long-standing sac, one may consider excising, but one should be very cautious. Once you excise the sac, you have to give very good sutures around the cartilage sac so that it does not bleed. Okay. Patient has refused operation for hydrocele. Anything else can be done? Patient is saying he doesn't want to get operation, or he has an interview to appear next 2 days. Anything else can be done short of a surgery?
Go for aspiration and putting sclerosing therapy.
Is it a acceptable procedure now?
So we usually do not.
Right. It is an acceptable procedure now. There are a lot of publications. There are a lot of publications that people are saying that, and then the success is claimed to be 70 to 80%. What sterogen you can use? For this, you need to aspirate the whole hydrocele amount so that these two layers will be almost meeting. And then what do you inject after aspiration? What are the different sclerosant that can be used? Simple, one antibiotic. One antibiotic is a sclerosing agent. Mitomycin is not an antibiotic in this sense. Terramycin, tetracycline. Injection can.
Is it, Professor Saha, is tetracycline available now? Probably that oxytetracycline or tetracycline is not available now.
Yes, yes.
Sometimes we prescribe it, but we never get it. Is the
Now the standard is either you use STD or proldecon. Okay, so these are the different sclerogenic use. The problem of sclerogent is there is higher chance of recurrence. If you are not aspirated completely and this sclerogent may not be effective, it can cause recurrence in some other type. Recurrence is a little higher.
Remember, Indrani, remember aspiration and injection of sclerosing agent, recurrence is high, and also the chance of infection is very high. Once there is an infection in a hydrocele sac with a sclerosing agent, that will make too much tension on the patients as well as on the doctor, because infection following aspiration therapy is not wanted. Okay, for that reason particularly, it is not a popular technique. But till it is done before interview by a military person. So for example, a young boy is appearing in an interview for a military service, a military job. So he wants, there is no swelling. So you can do the aspiration with risk with antibiotics only, but may not be only sclerosing agent. That is a temporary one. Okay. So before we have only 5 minutes.
Sir, so if we are putting the sclerosing agent, sir, then do we have to repeat the procedure or just we have to do it for once? Like, I mean, I don't know.
Yes. One is if you have done a good aspiration, good sclerosing, it can be effective. As I said, this success is 70 to 80%. So if there is a recurrence, you can try another session of sclerosing therapy, or you can go for surgery. So sclerosing therapy may be repeated. But again, you see, understand, once there is a sclerosis in the sac, the chance of injury is higher unless you are doing ultrasound guidance.
Okay, so we have only 5 minutes, Indrani. I am just making some rapid fire questions. So what are the different incisions for eversion of the sac? One is paramedian. What are the other incisions? Quick.
Transverse incision, sir.
Transverse incision.
If I am to do a bilateral,
single median incision.
Bilateral, if you do a bilateral version of the sac, you make a midline incision along the raphe. So in that case, you can approach both the scrotal sac with a single incision. Okay. So suppose there is a hydrocele sac on both the sides. After completing the right one, you do like to do the left one. How do you approach to the left one? After completing the eversion of the sac on the right side,
you make a right paramedian incision.
Eversion of the sac on the left side. What will you do? You will how do you approach to the left side after making a midline? You have made a midline incision or along the raphe. Then you have completed your right operation on the right side. Then how will you go to the left side? Through which area?
Through the same
septum. So the
same
answer should be go to the septum.
There is a septum in between.
In between. So you have to stretch the septum.
If you go by midline, there is a scrotal septum.
Okay. And then tell me, can you do you ever do the eversion of the sac? Eversion of the sac. So incision other than the scrotal incision? Is there any indication of doing eversion of the sac through incision other than the scrotal incision? Do you understand my point? Am I audible?
Repeat. Repeat the
question. Okay. Suppose, is there any indication of doing eversion of the sac through incision other than the scrotal incision? Can you do eversion of the sac through incision other than the scrotal incision, or you may not need any scrotal incision? You can do it through other incision. Inguinal incision.
Sir, from inguinal incision we can do, sir.
Yes.
Sir,
when you are doing operation for hernia,
hernia and press hydrocele, then we can approach it from the same incision.
Yes, that is the answer. What is the role of assistant during the eversion of the sac? Important role of assistant. What are the important
Sir, to
steps?
hold the sir, to hold the sac and the scrotum properly for the proper exposure.
Okay, when we are making incision on the scrotum, so that holding of the hydrocele sac by the assistant with his 2 fingers, 2 hands is very important, because the stretching is very much needed, and he should relax the stretching effect when you are very close to the sac. Otherwise, you make a incision on the sac. You should avoid the incision on the sac. The assistant should make little relaxation of the stretching. And in other important job the assistant should do what Professor Shah has mentioned. When we are separating the sac from the internal spermatic fossa, then the surgeon's both hands are needed. He should stretch the internal spermatic fossa away from the hydrocele sac, and then the assistant should hold the margins of the incision away. So there the assistant will be busy in holding the scrotum or hanging the scrotum, and the surgeon's both hands will do the work of separation of the internal spermatic fossa from the hydrocele sac. What is Sharma's operation? What is
Sharma and Johor. That was there in earlier Burial Lab. In fact, I was asked this question during my PGI entrance examination.
That is omitted.
What is
But
linear?
remember, any old examiner like us, if he is there, if Professor Shah is there, if you are doing well, when you are very close to 90% or 80% mark, then he may just throw this question. That is a technique.
But it is not there in Burial Lab now.
But you should know from your teachers, you should know, because if there is a old examiner, then it may be asked, why not? That is a contribution of an Indian surgeon. So you should know it. If you know it in a history, as a history or evolution, you should know it. That comes as a evolution or history in the surgery of hydrocele sac.
It is also described as minimal dissection technique for hydrocele operation. That you incise the skin, and what he's trying to say is you create a subdermal pouch. You create subdermal pouch for housing the testes, and then you reach out the testis is taken out from the sac, and testis is placed into the subdermal pouch. So now testis out of the tendinovalis sac, and he is trying to describe that this is a minimal section technique for hydrocele operation. Not very popular now, but just a point of interest.
Dr. Indrani, there is a question in the chat box. So what is hydrocele of the canal of Naak? What is the hydrocele in the hydrocele of canal of Naak? There is a question in the chat box. What is that?
Canal of Naak is found in where? Male or female?
Female.
Female. So
what is that actually? That is just a hydrocele in the processus vaginalis in the female.
yes.
Okay. And the treatment will be same as in particular child, it is the herniotomy or just excision of the sac. If it is a hernia of the canal of Naak in a female, you can just do a enucleation, excision of the sac. Okay, there you should not do the eversion, because that is very easy to excise the sac. Any question? So we have no time. We have just reached
Yes.
time.
No more question. Thank you, Dr. Maiti. Well covered. This is a maximum required for a MS or DMB examination. Okay.
And remember, Indrani and all the PGTs, hydrocele operation is a very easy operation. But if there is a complication in a hydrocele operation, they have caused too much botheration to the surgeon. We know there is history of orchiectomy after hydroversion of the sac.
Orchiectomy, blood transfusion for patient of hydrocele. Yes.
Second operation, taking the patient for the second time to the OT. This is not so uncommon. It is not rare. Orchiectomy, I have seen.
Wound breakdown, lot of complications.
Went for hydrocele operation, we had to go for operative.
Yes.
And remember the common site of bleeding following hydrocele operation. There are 3 important sites. One is the margin of the hydrocele sac. Another is the deeper surface of the everted sac. So the surface of the sac, what we have everted, from the deep surface, there may be some bleeding. So sometimes the drain is placed in the form of a Y. One prong of the Y is kept deep to the suture line of the eversion of the sac. And another site is the margin of the spermatic fossa, what an incision, what we have made in the scrotum. From that margin, there may be bleeding. So these are the three important sites from bleeding occurs. So when we are doing the eversion, take proper care whether there is any bleeding from the outer surface of the tunica vaginalis, which is going deep, which is now being undermined. Next is the your internal spermatic fossa surface and the margin of the sac. So these are the sites you should check. Okay.
Thank you.
Another thing,
Thank
the
you.
suture removal. Professor Saha have also the experience. So scrotal skin is wrinkled. So if there is multiple sutures you have applied, many patients returns after a few years. We have seen many patients after 6 or 7 years, a patient has come with a suture in the scrotum that remain undisturbed. For example, nylon suture is there, that is not causing a disturb, that is just moving. And because of the wrinkled skin, sometimes when removing the suture, 1 or 2 suture may remain there, may be left unremovable. You may fail to remove one of the sutures. So take care that all the sutures are removed when the patient comes for the removal of the suture after operation in the follow-up.
Okay, Dr. Maiti. Thank you.
Thank you.
Thank you. Thank you very much. Sure. कल क्या है?
सेमिनार